Our next speaker is Michele Ledgerwood. She's a good friend of mine, and we have both been friends and worked together for about 20 years. She is an expert in many things, including national security, bioterrorism, public policy, health information technology. Currently, she is a consultant for a variety of high-profile think tanks, all of which have some sort of interest or initiatives in global health. And she's going to talk to you a little bit about the use of social media in public health and humanitarian efforts.
Thank you, Gretchen, and thank you to SAGES for inviting me to speak today. It's really an honor to be up here with this incredible panel. And as Gretchen said, although I am the only non-physician on the panel for the last 20-odd years, my work has been at the intersection of national security, medicine, and science, which isn't always an obvious intersection, but there are a lot of very interesting sandboxes there. And in the last couple of years specifically, I've worked primarily with bench researchers who are focused on infectious diseases globally and neglected tropical diseases, all of which, of course, have symptoms that affect the parts of the human anatomy that this particular group tends to focus on most closely. So in the short time I have today, I have nothing to disclose. I should probably say that first. In the short time today, I'm going to talk a little bit about some very concrete examples of how all the tools you have just heard about over the last hour or so have been used in a broader public health and global health context, as well as a humanitarian response context. And these examples are all designed to prove the point that social media is not something that can be ignored. It can be used for the greater good. And it strikes me that social media is uniquely suited to this particular audience, this particular subset of clinicians, for four primary reasons. One is that there's a tremendous diversity in the number of illnesses and the range of diseases that all of you treat and prevent in the procedures that you perform. In doing so, you also use an incredible range of tools, techniques, and technologies. I hesitate to use the word cutting edge among a group of surgeons, but you really do have to keep abreast of where the cutting edge is in all of these different areas. Third, there's a tremendous educational and mentoring component to what you do. And fourth, and I commend you for this, SAGES does have a humanitarian mission. A lot of you engage in humanitarian activities in your spare time, and there's a big application for that in social media. So to reiterate what Gretchen said at the beginning of the talk, social media is not a fad. It is a fundamental shift in the way in which we communicate. If that isn't already obvious to you from the previous sessions, I hope it will, or the previous talks, I hope it will be at the end of mine. So how are surgeons using social media? You've already heard a lot about that. Perhaps this slide should be titled, How Should Surgeons Use Social Media? Because we've heard a lot about where there's been hesitation in your various fields. I just want to highlight a couple of very specific points. We've heard a little bit about the push side of communicating on social media, what information you can put out there. I want to stress also the pull side, because the way I look at these social media platforms in aggregate is you have an entire team of research assistants, physician's assistants, peers, and colleagues at your fingertips for free, who can provide you with all the information you need, who can help to alert you to clinical literature citations that you otherwise would not have found, or can help you find relevant information before you would have found it with just a regular web search or waiting for peer-reviewed journal articles to come out. So that, to me, is a tremendous capability that social media offers to you as a tool set. The second is it enables you to track the innovation. I was talking about the tools and technologies and techniques. Again, you will hear a lot of things on platforms such as Twitter before you see them in the traditional news media, and certainly before you see them in peer-reviewed journals. And last but not least, I wanted to highlight the fact, there's a very interesting article that came out, a couple different studies actually that have come out recently that have tracked tweets in particular over a span of 3 or 4 years, and looked at citations of journal articles on Twitter and compared them to formal citations in peer-reviewed publications down the road. And it turns out that Twitter is an excellent weather vane for citations. The top mentioned tweets in the 3 days after an article is published will be a harbinger of the top cited articles down the road. So if you have something you're publishing, you throw it up there on Twitter and see what the reaction is, because that'll give you a sense of what to expect as the more formal literature comes out. So if you've been listening to all this today, you're kind of new to social media, you're feeling a little bit intimidated, you're thinking, oh my goodness, I'm late to this game. Actually, you really aren't, and you're not alone. As it happens, most significant government agencies, healthcare institutions, and medical societies have really only had a formal social media presence for 2 or 3 years. And you'll hear a little bit from Alan about how SAGES has handled social media and come up to this platform. But for a lot of people, this is something very recent, really since 2009 or 2010. And one of the things I always like to highlight is that what got the political and medical leadership of our country onto social media platforms was, in fact, a medical crisis. It was the H1N1 influenza outbreak in 2009. And as you've heard from other speakers already today, and whether you like it or not, consumers are increasingly getting their medical information as well as their breaking news from social media outlets. And what happened in 2009 with the H1N1 outbreak was actually quite interesting. A lot of the initial information about the outbreak, about the early cases down in Mexico, and as they gradually spread around the United States, were appearing on social media platforms, they were appearing on blogs, they were appearing on NGO posts, on different websites. And government and international organizations, including the World Health Organization, really didn't have a viable online or social media communication strategy to get credible information, up-to-the-minute data, and prevention tips, for example, out to the public. So what happened, and then meanwhile on platforms, particularly on places like Twitter, you had a lot of misinformation, hysteria, bad advice floating around. So what happened is that an entire global community of scientists and medical practitioners self-organized on these social platforms, meaning they came together, they spoke with each other, and they essentially did 2 primary things. One was that they debunked the myths that were floating out there, they corrected misperceptions, and they steered people towards credible sources of information, and also towards experts, people who could provide the right kind of advice. And what happened eventually is that the organizations that should have been providing this information in the first place got on board, and in May of 2009, the White House established finally its formal presence on Facebook, MySpace, and Twitter. And the CDC, which actually was an early adopter of social media, dramatically changed the way in which it used social media platforms to communicate its information. So it started posting a lot more frequently, more useful information, links that people could access from their mobile phones, and made their whole presence a lot more dynamic and a lot more relevant. So the second case study I want to touch on is a little bit different, and this has to do with the medical response to the earthquake in Haiti in 2010. So 2 years ago in January, you probably all remember, a 7.0 earthquake hit Haiti. And there was tremendous damage to the infrastructure. And what happened is, of course, a lot of people got trapped under rubble all over the country. But what was interesting is, in spite of this infrastructural damage, which within about 24 hours, cell towers were back up and running. And a lot of people who were trapped in the rubble had mobile phones with them. And so they were able to send text messages to an emergency SMS short code that was set up and broadcast out via radio and through the cell phone networks. They also had access to social media, and people in their communities who were around them were putting posts on Twitter, on Facebook, on blogs, on NGO websites that were saying, hey, I'm next to this building, there are 10 people who are trapped in there, how can we get help? And this, unfortunately, the traditional disaster response communications approaches were not suited to handle this kind of informal information coming from social media platforms, coming from text messages, and so on. So this rather extraordinary group of NGOs, this isn't all of them, some of them listed here, and those are their Twitter handles in parentheses, follow all of them, they're exceptional groups, but Ushahidi, Frontline SMS, Instead, and others basically came together and were able to develop a platform and use existing crisis mapping technology. They aggregated all the information that was coming in from social media, from text, and from these other informal sources of information, and they were able to map out the locations of people who were trapped and direct emergency services to get to them and pull them out while they were still alive. Subsequently, they were also able to use the same mapping technology to get medical help where it was needed, to identify where the worst injuries were, people who couldn't get to hospitals because they'd been leveled or where there weren't mobile clinics, or to direct the mobile clinics themselves to the areas with the greatest need. This technology was also used to identify areas in need of shelter, food, water, et cetera. And it ended up being used by all of the major international organizations on the ground. And one of the interesting things that I like to highlight too was that one of the interesting applications was Twitter and Facebook specifically were used to recruit Creole translators all over the world who are available 24/7 in different countries and were able to translate the text messages and other data that were coming in and translate them into English to facilitate the mapping using the crisis mapping technology. So the bottom line from this particular case study is, again, social media is not a fad. In this particular context, after the earthquake in Haiti in 2010, the ability to harness the power of social media saved literally hundreds of lives. And my last case study follows a little bit on the first one. This is more in the realm of infectious disease. It was the cholera epidemic that started in Haiti. The first outbreak was reported in October of 2010. And the epidemic spread within a matter of weeks to every single department in the country. To date, almost 500,000 cases have been reported. More than 7,000 lives have been lost to the epidemic. So this is a fairly significant medical event in Haiti, and it's also spread to the Dominican Republic, and there have been a couple cases reported even in the United States. So traditionally, when you're tracking an epidemic, epidemiologists and others are looking at two categories of information to identify clinical cases and also community reports of patients who are presenting with different symptoms. One is the traditional outlets. These are hospital reports. These are surveys of community health clinics. These are reports coming out from official government agencies and medical agencies, medical NGOs. The second are more informal sources. They're social media posts. They're internet-based news outlets. Again, NGO websites, blogs, etc. So a very interesting article was just published in January of 2012 in the American Journal of Tropical Medicine and Hygiene. It's a very interesting read. It has a lot of data, and it goes through their methodology, which is also quite telling. But essentially what it found is there was a very close correlation between the data that came out from the informal outlets and the data that came from the more traditional sources of epidemiological tracking. There was a very close correlation, and the primary difference was that the informal data was coming out up to 2 weeks ahead of the formal data. What are the implications of this? Well, it suggests that there may be cheaper and more accessible ways of engaging in disease surveillance, particularly in countries where a lot of you do your humanitarian work with limited resources or in austere environments such as post-disaster or post-conflict zones. Can we use these largely mobile phone-based, less traditional means to get that data out more quickly? Secondly, it suggests that we may be able to provide early warning of medical crises and possibly anticipate the patterns of the spread of specific epidemics. Is this a panacea? No, not yet. There was a conference last month in Boston on digital disease detection. Some of it's archived on the web, very interesting meeting, and it suggested that while social media holds a tremendous potential in the realm of epidemiology, it's still very much in its infancy. So that's all the time I have today, and my slide went down, but I was going to say, if you want any more information on any of the case studies I talked about or would like to hear other case studies, I have a whole file of them. I'm michele.ledgerwood@gmail.com, and you can follow me on Twitter at piningforfjords. If any of you are Monty Python fans, you'll know where that comes from. So thank you very much for your time.